Good evening. Good evening to one and all. I can see quite a number of participants already logged in. Good evening to Dr. Nivetha ma'am. So as has been the good evening ma'am. So as has been the case with ISCBC, since Dr. Ritesh and Dr. Gaurav took over charge, the thrust has been more towards holding more and more academic events, and we're doing quite well. We had in fact organized 3 or 4 CMEs at various centers in the city, because now Bhubaneswar has many postgraduate students. So post-graduation teaching now is not only restricted to the formerly top 3 medical colleges, but also now in Bhubaneswar. So in towards that end, we decided that we will have regularly bi-monthly CMEs. So we organized actually one in Apollo, one in Kalinga, one in IMS, one was about to be organized in Kings, and then the pandemic hit, and all those things went on the back burner. But now ISCBC in cohort with Kings organized entirely online conference. I hope many of you have witnessed that it was a fairly successful one. So we all came together, and Dr. Gaurav, who is always very active and always wants to be on the move. So he thought that without wasting time, we should start with academic events once again. So we'll start off with neuroanesthesia module, and the target would be the postgraduate students, of course, but at the same time, anybody who was logged in, I can assure you to be of really top quality. We have some fantastic speakers, and without wasting further time, and I think our moderator for the evening, Professor Nivetha Pani, needs no introduction, and so all who are attending would surely be familiar with ma'am. So, ma'am, I would request you to kindly take charge for the evening for all the talks. And thanks, Dr. Randir, for letting me use your screen on an emergency basis. I would once again, on behalf of ISABC, priorly thank all the speakers for finding some time to prepare the slides for the session. Thank you. Over to Nivetha.
Thank you, dear Jita. Good evening to all. Am I audible?
Yes, ma'am. Here.
So to start with, as you all know, that administration of the anesthetic agents, fundamentally, it shifts the responsibility for the maintenance of homeostasis from the patient and their interesting physiological and regulatory mechanism to the anesthesiologist. Our understanding of this regulatory mechanism and the effects of anesthetic on them has been driven by the tireless work of pioneers in the field. Herein, we will know the physiological determinants of the cerebral blood flow and how delivery of the anesthesia impacts the process. Here with us, Dr. Bimal Kumar Sahu. He is MBBS, MD, DM, Consultant Neuroanesthesia and Neurocritical Care of the Care Hospital, Bhubaneswar. First of all, to this August gathering, I am welcoming you, dear Dr. Bimal, and kindly enlighten with your knowledge on implication of the neuro autoregulation in anesthesia. Thank you. Over to you, Dr. Bimal Kumar Sahu. Are you there, Dr. Bimal? Dr. Bimal?
Ma'am, we're just starting our screen sharing.
Okay, no problem. No, we want to see Bimal also. Good evening, Bimal.
Good evening, ma'am. Namaskar. Just 1 minute, ma'am.
Okay, carry on.
Next.
Can you see the screen, ma'am?
Yes, we are able to see the screen.
Good evening, ma'am. Good evening, everybody. Actually, I will thank you, ma'am, that you have given me opportunity to present something in the ISA. So I'll be glad to present you. Today, my topic is implications of autoregulation in neuroanesthesia. So, actually, let me introduce myself. I am Dr. Bimal Kumar Sahu. I did my MD in PGI Chandigarh and DM in neuroanesthesia in Chitra. So currently, I'm working as a consultant in neuroanesthesia in Care Hospital. So my topic is implication of autoregulation in neuroanesthesia. So basic topic I will be giving about what is autoregulation and how it is helpful in different parts of neuroanesthesia, like any tumors, AVMs, your SH, and some part about the ICH. So before coming that, let me introduce what is the called autoregulation. Autoregulation is the maintaining of a constant cerebral blood flow over a wide range of cerebral pulse pressure. That is called autoregulation. So cerebral blood flow will be dependent on the cerebral blood pressure, cerebral pulse pressure, and cerebral pulse pressure will be calculated as the mean arterial pressure minus intracranial pressure. But at some point of time where there is a JVP, your more of your jugular venous pressure will be higher than ICP. We will take the jugular venous pressure instead of ICP. So CPP will be MAP minus JVP. So, but in normal patients who are coming without any comorbidities, we can take that MAP minus ICP is the CPP. So cerebral perfusion pressure will determine how much blood is going into the neural tissues. So autoregulation is otherwise called myogenic control. It occurs by the vasoconstriction or vasodilatation of cerebral vessels in response to the change in mean arterial pressure. So what is most common thing to confuse the PG student is the autoregulation and the regulation due to the CMOR2 and the regulation due to the CO2 responsiveness. So both are actually distinct phenomena, and autoregulation is basically a myogenic control. So if there is a stretching of the your smooth muscles of the tunica media of the brain vessels, they will in response try to minimize the changes in the circumference or the diameter of the blood vessels in the brain. So that is basically a protective mechanism to maintain the your cerebral blood flow. So either it is an increase in blood flow or decrease in blood flow, brain will try to minimize the changes in blood flow inside the brain. So that's called the cerebral blood flow and the autoregulation. The other things that will get confused to the students is the cerebral metabolic rate any changes, because that is different mechanism in which there is any hypoxia or any oxygen defect in the neuronal tissue. They will secrete the basically acidosis environment, and that will cause the vasodilatations. And locally, that is more helpful to changes in the blood flow inside this some part of the brain. So that is called the CMR2, and some part like hypoxia changes, and it will also helpful in the CO2 responsiveness. So their mechanism is different, and autoregulation is different because it is the myogenic control. So now coming to the mean arterial pressure and cerebral blood flow relations. Usually cerebral blood flow is maintained constant at the mean arterial pressure of 50 to 150 millimeter of mercury. That I have already told you. That even if it changes the blood pressure from 50 to the mean arterial pressure from 50 to 100 or 120, the exact cerebral blood flow to the going to the brain will not change. Because it is a protective mechanism of the brain to protect from the low blood flow or higher blood flow. So, but if the ranges changes from 50 below 50 or above 150, then there will be difficulty in maintaining the cerebral blood flow. So the MAP is less than 50, the maximum vasodilatation cannot maintain the cerebral blood flow. And the MAP is more than 150, the maximum vasoconstriction also cannot maintain the cerebral blood flow within the normal range. So beyond this range, the cerebral blood flow is pressure dependent, and it varies linearly with the cerebral perfusion pressure. So this is the graph I want to show you. Basically, this is a parabolic graph. In the x-axis, we put the cerebral perfusion pressure. It's from 50, 100 millimeters, 150 and 200. And this y-axis will show the cerebral blood flow, that is for ml in 100 gram of tissue. and brain tissue a minute. So it ranges from 0 to 90. So normal range of cerebral blood flow around 50, it will come in the normal awake patient. It is what I'm explaining is the normal patient and in the awake conditions, not in the anesthetized conditions. So usually this curve is a parabolic curve. From this, that is like a lower level of autoregulation, and this is the upper level of autoregulation. From the lower level of autoregulation, usually it is a 50 to 60 millimeter of mercury, and upper level of autoregulation, it is around 150 millimeter of mercury. So within this range, even if the cerebral perfusion mean arterial pressure is increasing, the blood flow is remaining constant at 50 ml per 100 gram per minute. But if it is going below the lower level of autoregulation, that is below 50, you can see that cerebral blood flow is decreasing drastically. And if the cerebral blood flow is going towards the 20, that ischemic symptoms, that is EEG slowing and reversible cell damage will start. And it is at the 10 ml per 100 gram per minute, then isolatory ECG, but no functional metabolism will be there. And if it is less than 10, then rapid cell death and potassium will be released, and the irreversible cell damage of the neuronal tissue occurs. So, similarly, in the upper limit of autoregulation, beyond this 150 millimeter of mercury, there is a sudden increase of the cerebral blood flow. So that means cerebral blood flow will be directly dependent on the cerebral perfusion pressure. So there, what will happen? There will be severe hyperemia of the brain tissue, and it will increase in the ICP, and death of the patient can happen. So other things like shifting of autoregulation curve that I explained previously, this is a normal patient in the awake patient. And in some patients which are not normal, that is a chronic hypertensive patients or CKD patients or any different extremes of age. So there is slight difference of these values, and the curve will shift either to the right or to the left. So this is the shifting of the autoregulation curve. The shifting of the autoregulation is shifted to the right in chronic hypertensives. As you know that chronic hypertensive, they will have a mean arterial pressure more than what the normal patients, what you get in the normal patients. So chronic hypertensives, this curve will be shifted towards the right. That means the cerebral blood flow is maintained at a higher rate. The quantitative measurement is difficult and varies from individuals. So this is the most important part of this neuroanesthesia, that you have to find out at what value exactly this autoregulation will be maintained for that particular individual. So in the normal patients, it will be maintained, everybody will know, but in the patients which are already diseased, we have a higher ICP, who are already chronic hypertensive, or they are CKD patients. There you have to find out what exactly this mean arterial pressure will maintain the cerebral blood flow without damaging the primary disease process. So quantitative measurement is difficult and varies from individual to the individual. So this figure is showing that is a curve that is shifting of the right side towards the right side. It is a basically chronic hypertensive patient. In x-axis, I have put the mean pressure, mean arterial pressure, that is from 50 to 200. And in y-axis, again, the cerebral blood flow in ml per 100 gram per minute I have put. So that normal curve is the straight line, and what is the blank lines, they are called the right shifting of the curve. So right shifting, you can see that the minimum, that lower level of autoregulation is going towards at 70 to 80, whereas the higher level of autoregulation is going towards 175. So this type of patients you can get in the chronic hypertensive patients, where the normal curve will shift to the right. So in these patients, you cannot keep a mean arterial pressure that we are keeping in a normal patients. This is the most important part of this shifting of the curves. And this I told you again, that is this is all disease conditions in awake patients. Again, in anesthetized patients, this will slightly vary according to the type of anesthesia you are giving, whether you are giving inhalation or you are giving the intravenous anesthesia. So now other factors that is affecting the cerebral blood flow, but these are not exactly the autoregulation that I am explaining, but these are the factors that affect the autoregulation also in different mechanisms. So they are the temperatures. Temperatures, usually people are thinking the hypothermia is helpful, but nowadays you have to maintain the euthermia. Hypothermia is not so helpful, but mild hypothermia or euthermia is not preferred. Then prevention of hypoxemia is most important thing. The PO2 less than 60, they will cause severe vasodilation, and that is dependent on the CMOR2. And again in PCO2, usually from 20 to 70 it is PCO2 responsive, and we are expecting to keep it as a eucapnic, that is 35 to 40 millimeter mercury, or mild hypocapnia is also helpful to maintain the ICP. And anemia also, you have to prevent the anemia, and high CMR2 also, that is a vasodilatation, and you have to prevent this high CMR2 also by maintaining the depth of anesthesia, proper positioning, and your use of opioids. Then what are the limits of cerebral ischemia? At what level we can expect that there will be ischemia, there will be brain damage, and perioperative strokes are very common. So normal CMR2 in healthy young adult is at 40 to 46, around 50 ml per 100 gram per minute. Actually, it varies depending on the whether it is a white matter issue or is a gray matter. In gray matter, as the oxygen demand is very high, it is usually 75 ml per 100 gram per minute. Whereas in white matters, it is slightly less, so it is around 25 ml per 100 gram per minute. So average it is 50 ml per 100 gram per minute in a normal awake patient. So healthy awake patient will have ischemia near around 24 ml per 100 gram per minute. This is actually mean value. So again, this is different for gray matter as well as white matter. So gray matter will definitely have a higher value of ischemia, a higher threshold of ischemia than the white matter tissues. So anesthesia, what is happening in anesthesia is that it lowers the threshold of ischemia to 20 ml per 100 gram per minute. That is the most important thing in intra period. So you can have some more value that at lower level it will cause ischemia. So we are more protective under anesthesia than remaining under the awake state. And this thing usually used a lot during the stroke management, and people have used isoflurane during the ICU also to give brain protection, decrease the CMR2. But to some less extent it is used. But this is more of useful under anesthesia, that you will have a lower threshold of ischemia up to 20 ml per 100 gram per minute. But the neuronal injury is there, if there is a hypoxemia is there, or traumatic brain injury is there, they will increase the threshold of ischemia to around 40 ml per 100 gram per minute. So you have to be very careful in the intra period. If patient is coming as a traumatic brain injury or a stroke or perioperative stroke is already there, or any ischemia is you are suspecting, then you have to be very careful about this injury patients. So now coming to the variability of lower level of autoregulation. So lower level of autoregulation varies from person to person, that I already explained. So majority advised to keep the map around 70 millimeter mercury. So autoregulation is usually telling that map from 50 to 150, but some people use it at 60 to 150. But 70 will be usually is a safe value at which map can be kept, and without increasing the hyperemia and causing any damage to the brain tissue. So baseline map before the anesthesia give you an idea of the lower limit of the autoregulation. So this is the most important thing. What you see before taking the patient, you have to take a baseline mean atrial pressure. So this baseline mean atrial pressure will give you an idea whether the patient is a hypertensive or not. The patient will tolerate the normal MAP value we are expecting or not, and we can decrease around 15 to 20% value, and we can maintain that pressure during the intra period. So there are some studies. I will give something that Stagger et al. Demonstrated that awake normal TC patient, around 20 to 26% reduction from the baseline map is the lower level of autoregulation. So we can easily decrease the value from 12 to 26% from the baseline mean atrial patient. In hypertensives, a reduction of 10 to 21% of baseline map is a lower level of autoregulation. So hypertensive, we can decrease 10 to 20% of value. And that is the thing that is your stroke guidelines in ICS also advise that you can decrease the pressure during the critical care around less than 140, but not below that. So ischemia can develop at approximately 45% reduction of mean atrial pressure in a normal value. But if you get in a traumatic brain injury or in the stroke patient, this value will be very less also. So basically, here the crux is that we can decrease the blood pressure up to 20% without damaging the autoregulation of the brain, and without increasing the vascularity, without increasing the blood loss and the loss of during the intra period. So another patient, that is Besker et al. Studied 48,000 patients retrospectively. He found that there is a 61 patient has ischemic stroke within the 10 days of surgery. That is a perioperative stroke within the 10 days. He found that association strong if the intraoperative map is the less than 30% of baseline. He had taken that the mean atrial pressure in the intra period will be decreased by 30% in the 2 consecutive reading of 5 minutes interval. If that is present, then the patient will very high association of developing perioperative stroke. But out of that, only 13 had general surgical procedures, 42 had carotid endarterectomy, and 6 had tumors of the head and neck. So perioperative stroke, you can from general anesthesia point of view, the chance is very less, but still then it will have very high amount if you do not maintain the mean atrial pressure properly. So you can see that only out of 48,000, there are only 13 patients that undergone general surgical procedure that had perioperative stroke within the 10 days of the surgery. But other things like your carotid endarterectomy, that is known for the perioperative stroke, and 6 tumors of head and neck, that is maybe related to the surgery itself. But general surgery is very less, and this thing you have to keep in mind that mean atrial pressure has to be maintained to maintain the autoregulation. In another study, that Sarok et al. Demonstrated the mean atrial pressure of 50 to 55 millimeter mercury as well tolerated. He took all the patients that are undergone hip surgery in lateral decapitated positions, and all were given epidural anesthesia infusion also. So he found that mean atrial pressure of 50 to 55 is well tolerated and doesn't cause any stroke in any patients. So the crux of autoregulation is that mean atrial pressure below the lower level of autoregulation will lead to hypoperfusion and ischemia. And mean atrial pressure above the upper limit of autoregulation that will lead to the hyperemia and cerebral edema. So always keep in mind other factors that is not related to autoregulation, but they are important. The other factors like hypoxemia, hypercapnia, hyperthermia, and associated neuronal injury, and low depth of anesthesia, inadequate analgesia. This, even if you maintain the autoregulation BP and higher MIP, if you will not maintain this hypoxia, all these things, this whole thing will go wrong way. So that I explained only because to give you idea that hypoxemia, hypercapnia, they are most important to prevent. But then coming to the role of autoregulation in the mass lesions like glioma, I will give you some one point in glioma, in AVM, in aneurysmal surgeries, and to some extent to ICH. So how autoregulation will be helpful in short. So role of autoregulation in mass lesions in glioma, usually they are usually supratentorial in majority of patients are supratentorial in nature. So their size, vascularity, and locations are unique to the tumor. If the bigger size is there, so you can expect that a lot of edema will be there, mid-time shift will be there, increased ICP will be there. So cerebral blood flow will be, and cerebral perfusion pressure will be definitely deranged in those patients. And vascularity also, you can find a lot of tumors like meningioma, high-grade tumors, and glioblastoma. They are highly vascular tumors, and their location will determine also the uniqueness of the tumor. And these patients usually they go surgical excision, surgical decompressions. So anesthesia is very commonly used in case of the supratentorial tumors. So approach and procedure also determine the plan of anesthesia. So in this patient, there is the goal of anesthesia is that we have to maintain a stable and controlled cerebral hemodynamics. To maintain the stable cerebral hemodynamics, you have to maintain a stable cardiovascular stability first. Then you have to maintain the ICP. If you maintain the ICP properly and the cardiovascular stability, automatically the cerebral hemodynamics will be maintained. So usually you use the induction of propofol 1 to 2 ml per kg. That is a titrated dose you can give along with the opioids, fentanyl you can use. And with the NDMAR like vecuronium or cisatracurium, people can use it and you can induce it. And what is most important is that you have to stop the variability of the blood pressure during some particular points like your intubation, your pinning, your extubation, and some points in the intra-period like your skin incisions and your drilling. At that point where there is a maximum pain stimulus will be there, so change of blood pressure will be there. So in that point, you have to give some extra drugs or give some particular techniques that will decrease the variability of the mean arterial pressure. So intubation also for ativating intubation reflex, they can use the lignocaine IV you can use, or you can intratracheal lignocaine also give, usually 1 to 2 milligram per kg. And during the pinning procedure, you can give esmolol 1 to 1.5 milligram per kg, and with 0.5 milligram per kg of propofol, that will maintain a stable mean arterial pressure. And during pinning also, people use the local anesthetics during the pin site, that will give you very constant mean arterial pressure and constant stable hemodynamics during this pinning procedures. So local anesthetic injection at the pin site can be given prior to pinning the Mayfield clamp, and allow proper timing of drawing effect to give the maximum effect. That is the most important thing, how much time it will have the effect that you see. So other things that is most important is that tumors have edemas. So one thing that is having the tumors, they are called the vasogenic edemas and autoregulation. So during this edema, I want to give a short thing that there are certain things that are called vasogenic edema, others like cytotoxic edema, then hydrocephalic edemas. But most common that you find in the tumor, they are called the vasogenic edema. The name itself suggests that it is the blood-brain barrier defect that causes the edema. So tumor cells that secrete certain substances that will increase the blood-brain barrier of the brain vessels. So usually brains, they are lined by the endothelium, and there's a very tight junctions of the endothelium. They will not allow certain substances to pass through it. But as the permeability is increased during the tumor cells by these tumor cells, then there is certain solutes and water will dissipate through the brain vessel cells that will cause the edema. So that is called the vasogenic edema. Another edema that is most common you will find in the neurosurgeries, that is called the cytotoxic edema that we get in the stroke patients. But as far as glioma is concerned, we will be seeing the vasogenic edema very commonly. And these are all defect in the blood-brain barrier. And this vasogenic edema will respond very, very quickly to the steroids. And so that is the most important part of this vasogenic edema, and how autoregulation is helpful in these cases that we have to see. And the tumors in the supratemporal part are clinically manifest as mass with the edema. The edema is vasogenic, and it is due to the breakdown of the endothelial junctions in the blood-brain barrier, and intravascular fluid and proteins dissipate, causing the edema. Then edema, what this vasogenic edema causes is that is the loss of autoregulation in these parts. So cerebral perfusion pressure becomes dependent on the mean arterial pressure. So maintenance of the mean arterial pressure along with the steroids are the only method to maintain the cerebral perfusion pressure. So intraoperative arterial monitoring along with adequate depth of anesthesia is mandatory in these patients. So apart from autoregulation and myogenic control factors, so the intraoperative that I already explained, that decrease the CMR2, you have to treat the hypoxemia, you have to maintain the eukapnia, and you have to keep the mild hypothermia or euthermia. So these things already I have explained thing apart from the adequate things. Then other things like I will go into the AVM surgery and role of the autoregulation. So about the AVMs, I will give a short thing. What is AVM? These are all basically vascular malformations. There's complex tangle of abnormal arteries and veins without normal capillary beds. So this is a high flow shunting through the AVM in the brain. That is a low resistant flow. This is the high flow but low resistant flows through the AVMs. This is the most important thing, the AVM. So brain parenchyma, that is the surrounding AVM, that is called the vascular still syndrome. It is because whenever any blood flow will be there, they will pass through the low resistance pathway than going to the normal brain tissues. So this is a high flow but low resistance that will cause the ischemic tissue during the surrounding tissue, but there will be hyperemia during that due to that AVM area. So this lead to the chronic arterial hypotension in the surroundings in the brain. So there is a loss of autoregulatory mechanism in the brain tissue. So this is a loss of autoregulatory mechanism that will cause the normal pressure perfusion breakthrough. What is that normal perfusion pressure breakthrough? I want to explain that. Suppose in the postoperative period, they will remove the AVM. So now what are the tissue that was going towards the normal tissues, that tissues surrounding the AVM, they are usually chronically hypotensive tissues. So they are basically they are accustomed to that low blood pressure tissue, but once you remove that AVM, now the sudden gush of blood will go into this normal brain surrounding tissues. That will cause the ICH, intracranial hematomas, in the postoperative period. So even if you maintain normal pressures, that will cause.
Can we just wind up? It is already going to.
Yes, ma'am. Yes, ma'am. Loss of autoregulation is due to absence of capillary. So postoperatively mean atrial pressure has to be maintained in 60 to 70. So you have to maintain that 2 to 3 days. So like labetalol you can use. So intraoperative following to be smooth induction, smooth intubation, slow emergence, and strict blood pressure monitoring. Then autoregulation in the ICH is the same thing. Basically, you have to maintain a mean atrial pressure at a higher thing because of ICP will be higher. So normalization of hypertension lowers the risk of ICH. Autoregulation in ICH is very complex. High BP contributes to bleeding. Low BP do not improve the outcome. So lowering BP causes hypoperfusion as chronic hypertension as loss of autoregulation. So modest decrease of BP doesn't cause the hypoperfusion and bleeding. So basically explain to this how this anesthetic contraction is maintain the hemodynamic stability, avoid fluctuations of the mean atrial pressure, maintain the cerebral perfusion, brain protection during intra period, and low end of organ damage like AKI, heart failure, pulmonary edema. So autoregulation SH also same thing that I explained. The severity of dysregulation directly linked to the severity of initial ictus. Patients with cerebral dysregulation have high risk of developing delayed cerebral ischemia. The temporal profile of cerebral autoregulatory failure and its relationship cerebral vasospasm are poorly defined. So DCI is that thing I will explain later. The stages of autoregulatory failure in SH, that acute phase, one is subacute phase and delayed phase. Acute phase will occur 1 to 4 days, and in the subacute phase, this is usually the secondary injury to the subarachnoid hemorrhage. So it is a disruption of the blood-brain barrier, inflammatory response, oxidative stress, and leading to the blood-brain barrier dysfunction, and it lead to the subacute phase. And another thing is that last phase, that is the vasospasm phase, that is most important in SAH. So they demonstrated that delayed cerebral vasospasm itself can cause failure of autoregulation. This phenomenon could be interpreted as purely mechanistic. It is due to the compensatory distal vasodilatation impair the further vasomotor reaction. So treatment of vasospasm, that I explained that previously AAA therapy used hypotension, hypervolemia, and hemodilution, but nowadays hypotension is only preferred, and you have to prevent the hypervolemia. That's all. Thank you.
Thank you, Dr. Bimal, for such elaborative and making the brush memory all these things. Bimal, I don't think there is any question in the chat box. So I'll just have a question to you. You see, nowadays we are doing all the asleep, awake, and asleep technique, you know. So by using local anesthesia or conscious sedation to GA. So do you think what are its effects on the cerebral autoregulation?
Actually, as far as under normal conditions you are doing that, you have to maintain it at a higher mean atrial pressure you have to maintain. And second thing that because there is a chance of hypoxemia is more in the normal, and anesthesia usually protects the brain from hypoxemia. So mean atrial pressure has to be maintained properly, and secondly, at a higher level of mean atrial pressure you have to maintain in the awake patients as far as your brain hypoxemia is there. But awake, another advantage in awake is that even if some hypoxemia is there, patient will indirectly give you evidence that she is becoming unconscious, she is not responding. So you can increase the mean atrial pressure, you can see any other problems you are having or any seizures she is having. That thing you can have during this awake conditions. But under anesthesia, you cannot know unless you have that continuous EEG or your NIRS or any PBO2 you are using, or transcranial Doppler. That will give you an idea during the intra under anesthesia. But in awake conditions, you have that advantage of having that patients will itself will give you idea whether any problem is happening during the cerebral vasculature. But at a mean atrial pressure during awake is slightly difficult because patient itself during pinning and during apprehensive. That is slightly difficult during this maintaining the mean atrial pressure at that point.
Thank you, Dr. Bimal. First of all, welcome to this such a beautiful gatherings, and it's such a wonderful talk. We'll move on to the next this thing by Randhir Mitra. He's a MBBS, MD, and DM. He's a senior consultant in neuroanesthesia and neurocritical care, Utkal Hospital, Bhubaneswar. As you know, that recent advances in the pediatric neurosurgery have dramatically improved the outcome in infants and children afflicted with surgical lesion of the central nervous system. Thorough preoperative evaluation and open communication between members of the healthcare team are very important. A basic understanding of the age-dependent variables and interaction of the anesthetic and surgical procedures are very much essential in minimizing the perioperative morbidity and mortality. And it is a 100% fact. I confess in this August gathering that when a neurosurgical baby patient comes, that to infant comes, you must see our tachycardia, how much we get it. Am I correct, Randhir?
Yes, ma'am, and good afternoon to you, and good afternoon to all my fellow speakers, seniors and juniors. You're absolutely right. We always have a heart rate more than 100 when we see a baby. So with that note, let me begin the presentation. So, ma'am, is it visible, my screen?
Yes, yes.
Yeah. So I will present first of all some cases which are actually real life scenarios, and from that, what are we going to do? So let me start with the first case. 6-month-old baby presented to a PSC clinic with enlarging head, repeated vomiting, delayed milestones. Patient was is posted for BP shunt. So when you see the patient, what are your consideration for the patient? So a large-headed baby, and then the CT scan shows large ventricles, ventriculomegaly. This is one case scenario. The next case, when you have an 8-year-old girl posted electively for pineal lesion tumor, ASA1 investigation within normal limits, then what do you think when you see the patient? Obviously, this is a pineal lesion tumor, which translates to pineal lesion tumor. Patient will be done in a sitting position or in a prone position. In a sitting, modified cross technique, you will start thinking of whether to do the pediatric patient in sitting position. What are my considerations in sitting position? So all of this. A third case, 2-year-old child presented with sagittal suture fusion, scaphocephaly, delayed milestones. The cranium is limited in growth, so delayed milestones, and we are planning for strip connectomy. The surgeon says that I have this patient, and the patient is posted for surgery. So what are your considerations? So this is a scaphocephaly case, and then it translates to Sphinx position, and all other considerations like air embolism, blood loss, central line, all of that. So these are some of the scenarios, real life scenarios that you will get while working as a neuroanesthesiologist. So what are those problems? I will summarize those problems and I will deal each problem one by one. So infant or child, whether it's a small adult, what is the different physiology? What about brain, perfusion pressure, mean arterial pressure, ICP? I think already the adult part has been dealt very clearly by Dr. Vimal. We'll see a bit about the children. Then large head, syndromic faces. Whenever you see the patient, you start sweating. Airway challenges. What I'm going to do? Intravenous access, always difficult. Specific PSC advice. What kind of specific advice that you will give for the children? Then effective anesthetic agent. How to choose the appropriate one. Ventilatory strategy. What kind of ventilatory strategy you will have? Choice of fluid, blood loss, estimation of blood loss. Critical steps during each of the neurosurgery. There are different critical steps for each of the surgeries. Then how to look out for those. Position related problems. Tight brain checklist for a pediatric patient. How it is different. Then reversal versus post-operative ventilation, whether you will reverse or whether you will go for post-operative ventilation. What are those analgesias that you will do? Before we start out, let us look at this table. What are those factors in general which affects the morbidity and mortality of a patient who is being anesthetized? So as you can see that one of the high risk case is a factor is an infant and other is a neurosurgery. So deadly combination. So the first problem, how different is the physiology from the adults? And if you look at the differences between children and between a child and an adult, look at the head surface area, 18%, while the adult head is lower, almost half. So what does it mean? Larger surface area, more loss of temperature, more vascularity, more blood loss. These are some of the problems. Weight of the brain is more in comparison to the adult. If you compare it to the whole body, it is 11 to 12%. Fontanelle they give you some degree of relaxation from the raised intracranial pressure because the anterior fontanelle close almost by 2 years of age, 12 to 18 months of age. Posterior closes early. So you have some degree of relaxation, but then it is a problem because if the patient is presenting early, that means the ICP is quite raised and not being compensated by your fontanelle. So you should be aware that if the patient is presenting, it's very late. Then total body water. The total body water is obviously a bit higher. It is 65% for the infant. Fat content. The infant fat content is lower. So hydrophilic drugs have more binding sites and therefore they work in a prolonged manner. cerebral blood flow, you can see the cerebral blood flow, it is almost 12 ml per 100 gram per minute in a premature. But when you come to an infant, full-term neonate, it is 20 to 40, infants is 50. It is more than an adult. So you have to maintain the blood pressure in the infants too. Then cerebral metabolic rate of oxygen consumption and cerebral metabolic rate of glucose is quite high as compared to the adults. It is almost 50 to 60% of value, while it is 20% in case of adult. So it means that the blood flow, oxygen, glucose has to be maintained properly in children more so. And the role of arterial blood gas analysis, CSF volume, ICP. ICP normally neonates is 2 millimeter mercury, infants is 3 to 7.5. It is lower than in adults. So the most important thing is the autoregulation. You can see in like already Dr. Bimal said about the autoregulatory curve, the role of neonatal pressure or cerebral perfusion pressure, how it is maintained between the upper limit and lower limits. In neonate, the curve is shifted to the left. So since it is shifted to the left, it means that the latitude is still less. The slope rises significantly and lower and upper limits of the curve respectively are lower than that in the adult. So in full-term healthy neonates, they can autoregulate a bit. But remember, whenever you have a sick premature neonate or low birth weight hypotensive, it is always pressure passive autoregulation. There is no autoregulation as such. So the blood pressure has to be maintained within those range. Intracranial compliance, I've already said, because of fontanella, they have some compliance, but then if they're presenting with raised ICP, vomiting, sunken eyes, or motor posturing, then you know that the ICP has raised beyond normal, and it is very late. So you can see that in adult versus infants, in this second graph, you can see that the ventricular, there is some, because of the fontanelle, the ICP raise occurs later with a rise in the ventricular volume, but at the diminished volume, the ICP rises more quickly. This is what the Monro-Kelly doctrine in case of adult and in infant. There is some latitude more in infant than in adult, but then once it rises, it keeps on rising. Then these are the effect of hypoxia. Hypoxia decreases cerebral blood, causes vasodilation, increases cerebral blood flow, and same effect of carbon dioxide. But as like in adult, we have to be very careful while hyperventilating, and cerebral blood flow changes very little until there is severe hypocapnia. So there is less effect of moderate hypocapnia in newborn, but more than age of 2 to 4 years of age, that is almost levels are almost similar reaction to hyperventilation. And the estimated blood volume, we should always know how to calculate the blood volume in neonate, full term, in neonate, preterm neonate, less infants and infants and above. So rest of the system, cardiovascular system is immature. So because of that, they are more susceptible to volatile agents, calcium channel blockers. As we know that they are heart rate dependent cardiac output. If volume loading won't help, and so we have to be careful. Blood for blood. That is what we say. When we get a pediatric patient, blood for blood. Blood is lost, give blood. Kidney. In kidney, the renal blood flow GFR doubles every week after birth and almost reaches adult level of 2 years of age. So in between 2 years, any patient less than 2 years of age is immature kidney, so has difficulty in handling salt and water. Liver is immature, and so there is always you add glucose, 1% dextrose to the maintenance fluid, because there is more chance of hypoglycemia, especially in case of newborns and neonates. So what are the airway challenges? So like we all know, we have been cramming throughout the whole anesthesia MD that these are the features of pediatric airway which are different. Narrower airway, larger tongue, floppy epiglottis, anterior larynx, acute angulation between epiglottis and larynx, angulated cord, funnel separated larynx, narrowest postnate cricoid, and all of that. What it tells you that the pediatric airway is a difficult airway. We should be prepared. So apart from seeing a child and deciding that it has a difficult airway, apart from that, what are those features which will tell you actually? Dysmorphic features, widely spaced eye, hypertelorism, beaked nose, repeated UITI, cold, cough, always have a beaked nose or high arch palate, low hairline on forehead, one of the syndromic problem, can have a difficult airway, slung or malformed ears, craniosynostosis coming with some kind of syndrome can possess a difficult airway, microcephaly. So sometimes we have a hydrocephalic baby like the first case. then what we can do is we can raise the baby, keep the head level below your intubating level, and we can intubate, or you can hang the head in the side of the table, and or you can intubate in a lateral position. These are some of the things that we do when we face a difficult, a big-headed baby, or with a encephalocele, encephalomyelocele. IV access. For IV access, generally, if there is no IV access preoperatively, then and the elective case will ask some, you will put an IV access, or you will ask the pediatrician, or if it is shifted from NICU, tell them to put an IV access. But if the patient comes to you, no IV access, obviously you have to, if there is no issue of raised ICP, you can take it on inhalational induction and take an IV line. If there is a patient of raised ICP, still put it on inhalational induction, go for hyperventilation once the patient is apneic, so that you can keep the ICP under control and take an IV line. Specific PSC advices. So routine investigation you always do: complete blood count, grouping, RH typing, urea, serum creatinine, electrolytes, coagulation profile, and chest X-ray. Apart from that, you will write an order for fasting guidelines. So clear fluid 2 hours, breast milk 4 hours, formula feed 6, solid food 8. But you should also know what are clear fluids: water, glucose water, Pedialyte, apple juice, plain jello, tea without milk, black coffee. Of course, you don't expect the baby to drink all this, but you should know what are those clear fluids. And always remember, don't be hesitant to do a 2-dimensional echo cardiography if you suspect that there is a suspected congenital abnormality, especially if there is a cleft lip, any midline, bladder dystrophy, anything. It can have a cardiac problem. Fifth problem, like effect of anesthetic agents. How can you choose the appropriate one? So you will know that IV agents generally reduce the intracranial pressure because of cerebral vasoconstriction, diminish blood flow, and therefore they can cause a reduction in ICP. But if you look at the table, almost sodium thiopentone causes more reduction in ICP than our favorite propofol. But when it translates to, when we look about tachycardia and all that, then somehow their effects are almost similar. Only except ketamine, where it causes a raised ICP, but then ketamine with some sedatives prior, like midazolam, etc., does not cause that much of raised ICP. But still, it is if you have a raised ICP in a child, try to avoid ketamine. Rather, you can use either propofol or sodium thiopentone, etc. Then in inhalation agent, all causes rise in ICP. In neurosurgeries, generally we prefer either sevoflurane or desflurane. But if you look at both of them, I think sevoflurane has an upper hand because the ICP is less raised than in desflurane. Pre-medication. In pre-medication, you will think of what pre-medication will give. You will, because a small child airway you are going to take, and then they can have a lot of salivation and all that. So you will prescribe an anti-sialogo. And rather, since you cannot give glycopyrrolate orally rectal, you give atropine. So you have to give atropine. Then, especially in COVID also, it is rather you have to give an anti-sialogo. And then any anxiolysis. Generally, it is avoided in small children because there is a chance of raised ICP if the patient has been operated for tumor or for any vascular surgeries. But if the patient like a child of more than 6 or 8 years of age, more than 6 years of age, and the patient is posted for spine surgery, then you can give some kind of anxiolysis. But Kenyan cases you will try to avoid. Anesthesia goals in case of pediatric surgery: avoid rise in ICP by mild keep oxygenation at the normal level. Mild hyperoxygenation more than 60 you can do. Normocapnia you have to maintain. Cerebral perfusion pressure is maintained at more than 40. Avoid hypotension. Maintain normal osmolarity. Do an ABG to see osmolarity. Maintain normovolemia. Keep on seeing the urine output, the tachycardia, the blood pressure, pulse pressure variation. Whatever you do that so that the blood volume is the volume status is normal. Avoid any gross head positioning, deviation in positioning. Like once you have intubated the patient, you have checked the patient, the air entry both in a normal state, and you have flexed the neck and you have checked the air entry. After that, once you have handed over the patient to the surgeon, tell the surgeon not to go for too much of neck positioning, extremes of extension or flexion. Then always prevent this, very important, prevent ocular and peripheral nerve injuries by patting up the patient, and temperature control. Induction, generally, it depends on what scenario you are and how you want to use. Basically, if you have a raised ICP, try to avoid inhalation agent, go for IV induction, give opioids and relaxants. And if the patient does not have any issue, like spine case, you can still go ahead with an inhalation induction and all that. And yes, IV selection, IV, if you want to select taken IV access, then obviously you have to put the patient on inhalation. So these are the agents that we use: thiopentone, propofol, ketamine, etomipride. You can use all of them, or you can use ketofol. Ketamine, I have said, when you have raised ICP, don't use it. Propofol can be used for maintenance of anesthesia and as well as for induction. The general way that we do what we do is an oxygen air if there is a raised ICP, or nitrous if there is no raised ICP, volatile agents, opioid, neuromuscular blockers, or TIVA. And the most important thing is maintain adequate depth of anesthesia. It's not like they don't feel pain or they don't have awareness. So you have to maintain it. Like you see, Bishop et al. Did a study where they found 8 to 10-fold higher rates of awareness in children. So what are the appropriate ventilatory strategies? So optimum ventilatory mode is one of the articles that came out in Best Practices in Research Clinical Anesthesiology regarding what should be the mechanical ventilatory mode. So what they found out is that there is they made a review, meta-analysis of those studies, all those studies wherever there is a pediatric and ventilation have been done, and they said that there is a direct relationship between peak inspiratory pressure and mortality in child. So generally, the trend is towards to go for pressure control ventilation. But remember, you should always, if you have used a cuffless tube and you are using pressure control ventilation, then tidal volume you have to watch always. If because there will be leak, the tidal volume won't come appropriately on the ventilator. Look for chest rise. Chest rise, gold standard. But if you don't have somehow it is deteriorating and you're not able to see, you have to rely on you adequately pack the oral cavity if it is a cuffless tube. And if you have a micro cuff tube or a larger child with a cuff tube, then you can always look at the tidal volume. If you are using a pressure control ventilation. If you ask me, pressure control ventilation, obviously number one choice, followed by volume control ventilation. Optimal PEEP, there is a study which was published in 2018 in BMC, where they found out, they have done a study which would be an optimal PEEP in anesthetized children. They found out at least PEEP of 5 centimeter water is okay. So not to until unless it is required, or you are expecting a diminution in oxygenation, or there is the major VQ mismatch, or there is an atelectasis, then you should always use around 5, like as in adult. Optimal tidal volume. Optimal tidal volume observation studies shows that the higher tidal volume has a lower mortality in pediatrics. But this is an observational study. You cannot draw direct inference from an observational study. It is an often quoted study of Erickson et al. And there will be a study from China, where Zhu et al., where they saw no relationship between tidal volume and mortality. So generally, the current recommendation that we derive from pediatric ARDS studies is that they generally target a tidal volume. We generally target tidal volume of 5 to 8 ml per kg of predicted body weight, not real body weight, predicted body weight from the height of the patient. And we can go as low as 3 to 6 ml per kg if the chest compliance is low. Chest compliance good, go for 5 to 8 ml per kg. Choice of fluid. Now, generally, it is choice of fluid. They can be managed. Any child more than 1 month of age can be given isotonic fluid. Previously, we used to give isolate tea. A lot of children died because of hyponatremia. Nowadays, it is isotonic fluid, and most of the time, only you will add dextrose 1% as the European recommendation. Only when you think patient will have a hypoglycemia. Which are those patients? Patients having hemihypertrophy, congenital abnormality, the diabetic mother, patient neonate of a diabetic mother or infants. Then these are the child who are having diabetic child. These are child who are going to have more prone of hypoglycemia. And also if the weight is quite low, more than 3rd percentile, when there is a long duration of surgery, etc. Then you can give a dextrose. Generally, it is given at 5 to 6 milligram per kg per minute. Or if you are forming a solution, make it 1%. Add 5% dextrose, 1 ml and 4 ml of normal saline. For blood loss, generally the replacement is, if it is less than 10%, no replacement. More than 20%, give blood. You always preoperatively always see the hemoglobin, take the hematocrit, form the maximum allowable blood loss. Very, very important in pediatrics. Not so you can always manage an adult effectively without doing MABL. But for pediatrics, make it a habit to write an MABL. And every pack RBC, if it is given at a rate of 10 ml per kg, will raise the hematocrit by 10%. Platelet and FFP, depending on how much loss is there, you can give it, especially when the loss exceeds 1 to 2 blood volume, then you have to give platelet FFP at the rate of 10 to 15 ml per kg. Colloids, albumin is favored. The data favors albumin as a preferred colloid. If at all you are giving colloid, and the volume is more important. So 5% albumin is preferred over 20% albumin in young infants. Now, what are those critical steps? Like suppose the first case, hydrocephalus. When you are tunneling the patient, there will be sympathetic response. At the time, you have to give some fentanyl to reduce those response, because tunneling will raise the ICP. Pineal region tumor, during traction of tumor removal, there can be arrhythmias because it is nearer to the brainstem. So you have to watch out for those arrhythmias. For craniosynostosis, when you are going for orbital frontoorbital advancement, and we are trying to lift the skull, at the time there can be shearing of the superior sagittal sinus. So at the time you have to watch these critical steps. And whenever there is a brainstem involved, you will always look for hypertension, bradycardia. If it is a fifth nerve involvement, seventh nerve, you look for any facial movement. If the patient is light, and then for 10th vagus nerve, you have hypotension, bradycardia, all that. Position related problem, generally if there is some physiological effect, there is some pathological effect. Physiological head and elevation, they are given for better drainage. So that is the reason neurosurgeons still prefer sitting position. But then there will be venous pooling, there will be edema of dependent organs, and there will be postural hypotension. So preload the patient, while even in pediatric, you have to preload a bit before going for head and elevation. Head flow, obviously there will be congestion of face and eyes. So for that you have to take precaution. For prone position, there will be venous congestion. So venous air embolism that can happen in proper position. The incidence is 0.4 to 9.8%. So for that you have to put a central line and ensure the central line is toward the right area. And
just 5 minutes you have to sum up, okay?
Yeah, ma'am. I'm going to just do. I'm almost done. So the tight band checklist says that for mild elevation, you'll always make it physiological. Don't allow the patient to be neck to be kinked. If there is a lumbar drain or the EVD, drain the CSF. Then hyperventilation, osmotic diuretics, all of them are always there. Most importantly, avoid kink tube, look for exhausted soda line, avoid excessive hypotonic fluid, and always, if nothing is there, then feel the surgeon has done something. The large vein has been coagulated. So mannitol for Lasix and hypotension all can be given in pediatric patient, except in traumatic brain injury, where there is level 2 and level 3 evidence for hypotonic saline or for mannitol. Reversal, it all depends on how your intraoperative course was. And previously, if there is an involvement of your lower canonical nerves, you will prefer to go for ventilation. Otherwise, rapid awakening, even in pediatric patients, are preferred. So analgesia, you have to give multimodal analgesia, blocks, and IV agents. So this is it. These are some of the formulas that will always mug and go to OT and always look at these formulas. Keep on looking, and as much as cases you do, you will be familiar with these formulas. Thank you.
Thank you, Dr. Randir, for such a extensive study and made it so compiled and so nicely. It is wonderful. It's a wonderful talk. In the chat box, there is no question. But however, I'll just have a discussion sort of thing. So see, actually, we are seeing that this AV malformation is very rare in case of the pediatric neurosurgery we come across. So I just have I want to ask you one thing. So once you do a clipping, suddenly we have a hypertension or hypermic cerebral edema occurs. So what should be the ideal drug of choice in pediatric patient do you prefer for this patient?
As like you said that the AV malformation are rarer in pediatric groups. Generally, a lot of them has been done endovascularly. But suppose you are talking of clipping, you are talking of cranial aneurysm, I suppose. And,
yeah.
You're talking of aneurysm. So generally after clipping of aneurysm, we tend to raise the mean arterial pressure or the systolic blood pressure. So generally in adults, it is very clear on how much you need to raise. In pediatric patients, we have to raise it. Generally, I have not done any pediatric aneurysm so far as a concern. But as the theoretical knowledge goes, it has to be raised over 20% above the systolic blood pressure. And generally, we use noradrenaline in adult cases. Noradrenaline and if required, we give vasopressin. Noradrenaline, I generally prefer noradrenaline.
If hypertensive crisis occurs?
So if after clipping a hypertensive crisis, that is what I'm saying. See, hypertensive crisis, generally we give labetalol. Labetalol is my preferred drug. Labetalol infusion or labetalol. And if the patient is already anesthetized, you can increase always the anesthetic agents. Propofol, you can always increase the dose. But yes, labetalol is the preferred drug.
Oh, so what is the role of nitroprusside on this?
No. We don't give any nitroprusside NTG in any neuro patient for the simple reason that there will be cerebral venodilatation and which will cause severe cerebral edema. So NTG SNP is out of question in any neurosurgical case. We have to remember this because as far as I'm concerned, I have never used it, never seen anybody using it, or no theoretical evidence in favor.
One question from Dr. Sri. What do you do when there is searing of the superior sagittal sinus?
I pray to God.
Sri, I think you have got your answer. Okay. Thank you, Dr. Amit. It's excellent
Thank you.
deliberation. Hope to see you in future. Now we move on to our third speaker, that is Dr. Natasha Roy. It's a wonderful, Natasha, to meet you in this such a beautiful platform. And I still remember you in the AIMS function. And Natasha is a MBBS and MD and DM. And she's presently the assistant professor of the AIMS Bhubaneswar. She's going to elaborate on the anesthetic management of the neuro patient for non-neurosurgery. And Natasha, I know when a brain tumor patient comes for a cesarean section and with her CT scan report when she comes, as a anesthetist, how you feel, that you know it very well. And also if any spinal tumor patient also comes for any laparoscopic surgery or anything, so how difficult we as anesthesiologists face. So I hope you will definitely enlighten us what should we do and how we will get protected and what to do to protect our patient. Okay, thank you.
Good evening, everybody. Good evening, madam. Thank you for nice introduction. And it's always pleasant to see you and listen to you as always. And warm good evening to all other IFA Bhubaneswar chiefs, Dr. Gaurav and Dr. Jeeta Bhai, and my co-speakers as always. Nice to see you, Bimal, after such a long time. So without much ado, I will begin. Actually, when this topic was given to me, it's such a big topic that I discussed with Dr. Gaurav that what all should we include. So I have included as far as possible I could, as per the PG curriculum I checked, which I have with me. So I have not included, like you said, Madam, brain tumors, but surely I will take this question at the end, and I would like to go ahead with it. But as per the PG curriculum, since it was a PG CME, so I checked the PG curriculum. As per that, I have checked and presented. So let's go on with the presentation. Is it visible?
Yes, Natasha.
Yeah, okay. Thank you, ma'am. So just a brief introduction. I am assistant professor in Department of Anesthesia and Critical Care from AIMS. And I would like to discuss the anesthesia considerations for patients with pre-existing neurological diseases. So our learning objectives for today would be to understand the basic pathophysiology, which has been actually already dealt with a lot of discussions in the previous two speakers, and any disease-specific perioperative adverse neurological outcomes which may happen in such patients, and the perioperative management. Now, since the advancement of the best of the medical care, a lot of geriatric cases come to us, and with various comorbid illnesses, which also includes stroke and neurodegenerative disorders. But with better perioperative care, better diagnostic neuroradiological and the radiological support is also increased. So better diagnostic support, we are able to diagnose diseases in the preoperative period and obviously provide a good perioperative care. So with that, I will like to begin. So when it comes to your mind, what first comes for an anesthesiologist in the mind is that what is the status of the neurological patient, what is the disease, what is the current status, how is the patient presenting, is he in an acute state or is he like in a chronic state. The next thing, the associated comorbid illnesses. Such patients usually do have a lot of comorbid illnesses which may worry us in the perioperative period, including the cardiac problems. Next thing is what amount of surgical risk, whether you are doing a lipoma surgery or you're doing a major abdominal surgery, always affects the perioperative outcomes. The last thing is that whether our drugs are safe or not for such patients. So let's go on with it. So first thing I would like to discuss is the intracranial vascular diseases. So as you know, stroke is the most common. It has got a huge burden, and recently it was seen that India has nearly 100%, as per the Indian Stroke Association, burden in India is nearly 100%. And you would be surprised to know, even I didn't know this, when I checked the statistics, I saw that the stroke incidence in India is the most common in this region. West Bengal, Odisha, and the northeastern part of our country. Is the most common and the incidence and prevalence is quite common in our area. That is only and solely because I think that the proper care of the stroke patients are not there, proper identification. We don't have a proper stroke clinics and also rehabilitation centers, which may amount to the stroke outcomes and mortalities. So what are the perioperative concerns? So when you think of the stroke, was it stroke basically arterial occlusion, just an artery is occluded and the region of the brain which is supplied by the artery gets infarcted and the patient presents with a stroke. But is that the area which we actually focus? It's actually not, because that's the irreversible damage which has happened, which you cannot do anything beyond the period of time. If not done within few hours, like 3 to 4 hours, or maximum within 24 hours, you may not be able to revive that damage. The area which we focus, or which we will be discussing as per this topic, is the penumbra area, which has got certain borderline kind of auto-regulation intact, or maybe, like it may have recovered from the acute part, but still not completely recover, and may again lead to perioperative stroke. So one of the major perioperative concerns is the perioperative stroke. Then comes the re-emergence of the neurological deficit. Will there be a re-emergence of the neurological deficit? Yes, certainly there are previous studies which have shown that if you give certain amount of drugs, like even our sedative agents, including the midazolam, that may also cause certain re-emergence of neurological deficit. And thirdly, like I already said, the problems related to the comorbid illnesses. So what is a perioperative stroke? It is basically defined by the Society of Neuroanesthesiology as a brain infarction of the ischemic or hemorrhagic etiology that occurs during surgery or within 30 days after surgery. That is defined as a perioperative stroke. So any amount of neurological dysfunction which is leading to stroke and it is occurring within 30 days, that's called as the perioperative stroke. Although the incidence is not very high, it may be higher in certain very high risk patients as per the NSQIP database in American Congress of Neurological Surgeons, but the mortality is very, very high as compared to the regular strokes which occur outside the hospital. That is because the two stress factors are occurring. First is a stroke, and secondly is a surgery, which both lead to production of the inflammatory response, and which may act synergistically, and it further increases the mortality. So what are the risk factors? There are certain patient-related risk factors like the old age, smoking, patient has history of migraine or any cardiac comorbid illness, and the surgical factors which lead to perioperative stroke, mainly the cardiovascular surgeries or the thoracic surgeries or the major abdominal bowel surgeries or transplant surgery. So these are the major groups where we have to focus and where we have to identify these patients so as to improve the best outcomes. So preoperatively, you should always evaluate that how much time since has elapsed since the last stroke event, or not only stroke, in fact, also the TIA. TIA are the small strokes which recover within 24 hours. And what was the treatment received during that during that period? What is the current functional status and the nutritional? These patients are usually nutritionally not so good because they may be bed bound and they may not be in our country. The nutritional status is a huge issue. And obviously the comorbid illnesses, medications, you should always note down what they must be on: some antiplatelets, anticoagulants, some beta blockers. So you should always take care because they may have perioperative implications. And also, like I said, the surgical risk, whether what is the invasiveness, what is the duration, what is are there any amount of fluid shifts involved, which may lead to, like already discussed by Dr. Bimal, that huge fluid shifts may lead to hypotension, and they may also increase the risk of ischemia. So optimal timing since the last stroke, like I already said, that it has been seen in a large cohort of around 5 lakh in elective surgical patients, that if you do a major surgery after 9 months after a stroke, this was a study done recently in 2014. So they found that after 9 months, it is usually safe. However, always you should remember that emergency surgery should never be delayed and it has to be done, but you have to identify and counsel the high risk patients. So preoperative carotid revascularization, is it any benefit in all patients? No. Routine preoperative revascularization in stroke patients compared to medical therapy has not been advocated as per the stroke guidelines and as per the European Society of Cardiology also. The guidelines have emphasized that the benefit of the carotid vascularization is highest within the first 2 weeks and generally should be performed within 12 weeks. After that, if the patient comes to us, usually the patient will not come within the first 3 months, usually will be getting it later, then there is no benefit. However, if you find the patient is having still symptoms and the carotid stenosis is more than 50%, you may still go for it. But then you should always remember that the patient will always be given some amount of antiplatelet drugs and all those things, which then you have to think that whether there is a risk of thrombosis or bleeding. Then perioperative anticoagulation. A lot of patients will come to you, which they will be, they will be having warfarin for some reasons. They'll be having mitral fibrillation and all those things. And whether you should continue it, stop it, or whether you should do some bridging therapy. So there was an excellent trial published in NEJM in the bridge trial, where they have seen that there is no benefit. If you have started warfarin, you can very well stop it, and there is no benefit of giving any bridging with the use of this low molecular weight heparin, and then you can very well restart it after 2 to 3 days of surgeries, and it is as good as giving up bridging therapy. So it's better not to give than to put a patient at risk of bleeding and all those things. So they are saying that there is no use of giving any bridging therapy. So you can very well stop the warfarin, and then you can wait for the surgery and like 2 to 3 days, and then you can restart the warfarin when you're very sure that there may not be any bleeding. So this is a very recent trial which you should definitely go through, the bridge trial. Secondly, similarly, the POISE-2 trial also came, and they advocated for the perioperative aspirin. So on the basis of that, they have formulated a flow chart on. They have found that patient on regular aspirin therapy prior to surgery, if it is an emergency surgery, definitely you have to go ahead. There's no question on it. But if it's an elective surgery, and if you're giving it for primary, whether you're giving it for primary or secondary prevention, then if not, then you can surely discontinue in the preoperative period. But if you're giving it for primary or secondary for prevention of some kind of cerebrovascular diseases, then as per whether it is a closed space procedure where there is a high risk of bleeding, where it may affect like intracranial or eye surgeries, middle ear surgeries, prostate surgery, where if there is some amount of hematoma, that will influence the outcome. So there you can hold the aspirin for 5 to 10 days in the preoperative, and again restart. Again, there is no role of giving any kind of bridging therapy with the use of the ticagrelor and all those things. If it is a non-closed space procedure like non-prostate, non-middle ear, like simple orthopedic surgery, then it is you can still continue the aspirin throughout the perioperative period. Perioperative beta blocker therapy, if the patient is on chronic beta blockade, then it should be continued perioperatively. There is no harm, but definitely there is no recommendation for the new initiation for the prevention. If tomorrow is a surgery and today you are doing PAC and thinking in the mind that I should start Metolar today and it will prevent, no, please, that's a definite no, that there should not be any new initiation for prevention. It has seen to prevent cause more of hypotension and more of intracranial hypotension also. Now, intraoperative management, both regional and general anesthesia are acceptable. In the current era, we have such anesthetic agents which are usually very safe. So there is no, as such, not much difference between regional and general anesthesia. Yes, definitely you have to see what are the various antiplatelet agents, and as per the guidelines, you can surely give it. And preoperative sedative medication better to avoid because like I said that even the use of midazolam in the range of 1.1 to 3 mg have been seen to cause unmasking of neurological deficits. You have to avoid relative hypotension. Shoulder surgeries in semi-sitting and sitting position are also safe, but here it is advocated to use a brachial cuff. You monitor the BP in the if you're using an NIBP. I preferably use to put arterial BP in shoulder surgeries for invasive BP transduced at the level of the tragus, so that you can very much maintain, monitor and also maintain the cerebral blood flow. The transfusion trigger threshold in such patients should be kept at higher level as compared to the younger patients. Like you can keep it above 9 grams so that the low hemoglobin may not cause an increased risk of the perioperative stroke. And also expect that some amount of delayed awakening will be there, and you should always have a differential diagnosis of why there is a delayed awakening. So you should always keep, like you should avoid hypothermia, you should avoid excessive dose of your anesthetic agents. The timing of your anesthetic agent should also be tightened, so likewise. And obviously the excessive opioids, because they are mostly the geriatric cases, so the principles of geriatric anesthesia should also be applied here. Now, what is not known is the optimal blood pressure management is still not known under patients with anesthesia to prevent the perioperative stroke, but maybe we'll be getting in another year. The POISE-3 trial is underway, so we'll be getting the results. And what are the various anesthetic interventions which can reduce a perioperative stroke, whether the IV is safe or whether the inhalational, that is again, I'll come to it. That is again a bone of contention, that which one is safe. But like I said, that if you are using a balanced anesthetic regimen, almost all the anesthetic agents of the current era are usually safe. So next we come to the unruptured intracranial aneurysm. So whenever in a hospital, we usually see a patient usually comes with a ruptured intracranial aneurysm to the neurosurgery OT or to the emergency OT, and the patient is taken up for clipping. Or if you have a neuroradiological suite, a good neurologist, neuroradiologist, then they can perform a coil embolization. However, there are certain incidences where even unruptured, I have not seen, but when I was speaking to Dr. Gaurav, he told me of an incident. That's why I have included this. And it has a prevalence in the general population of around 2 to 3%. However, the incidence of SAH from an unruptured is very low. It is just 0.7 to maximum up to 1% a year. The risk of rupture is, however, associated with the size, the location, whether there is a presence of a daughter sac on the aneurysm or not, and certain patient-related factors like the smoking, female sex, and family history. So this was a study which is published in 2018, and where they have seen whether the patients who were not clipped or coiled, the aneurysm was not secured and they underwent certain procedures under general anesthesia, and whether they had any problem. So they had done a study in around 110 patients where almost 68% were women, because I'm focusing on women because women have a higher risk of rupture, and the mean aneurysm size was also 3.5 mm, ranging from 1.5 to maximum of 17 mm. So total of 200 procedures were also done, and they had also included 2 patients where they did cesarean section under spinal anesthesia, and there were no immediate events of subarachnoid hemorrhage, and also in the follow-up period also they did not see that the general anesthesia precipitated the aneurysmal SAH. So another study which was published in Journal of Neurosurgery, and they have seen whether the vasopressor induced hypertension and subarachnoid hemorrhage in patients with coexisting unruptured. Sometimes patients come with multiple aneurysms, but surgeons usually will clip 1 or 2. They won't touch the unruptured one. Maybe you will come with a patient who has clipped 1 aneurysm, another aneurysm is still there. So here they have seen that for small unruptured, the frequency of the rupture is very, very rare, and we can safely go with the vasopressor induced hypertensive therapy. If you at all require, in any case when you need to give, then it is very safe. The hypertensive therapy is not going to rupture, but then again you should keep in mind that it's not that you will keep on increasing the BP. It should be very well in the limits of the autoregulation. So whether to clip the aneurysm or go ahead with the surgery, the question still remains. So based on all these retrospective studies and various other studies, they have given certain guidelines. The stroke people have given these guidelines. If the patient has history of SAH or there is a rupture of aneurysm, go ahead with the clipping or coiling. Please secure the aneurysm if there is a patient has history. If not, then definitely there's an unruptured intracranial aneurysm. Now, if there is it is unruptured, next thing we have to see is the size. If it is more than 12 millimeter in diameter, or if it is in the range of 7 to 12 millimeter diameter, but the patient is young, the aneurysm is in the posterior circulation, or the aneurysm is having a daughter sac, which places the risk for higher risk of rupture. All these three factors are the highest risk factors. Then definitely go for a definitive treatment, that is the clipping of the aneurysm or coiling, whichever method is available at your hospital as per your convenience. You can go. If none such factors are present and the size is very well less than 7 millimeter of diameter, then you can go ahead for a wait and watch method also, and you can go ahead with the surgery. In a pregnant patient, why I'm focusing, because most of the times pregnant ladies do harbor a intracranial aneurysm, and the risk of rupture is highest in the last trimester and during the labor, when there is increased cardiac output and which may lead to increased BP, and they may rupture. However, this has also been challenged in the latest studies where they're saying it doesn't, but still there is a risk. We do see pregnant patients who land up in FEH in the last trimester. So in pregnancy with headache, the aneurysm is always to be ruled out. So early pregnancy, you can say you go for clipping the aneurysm, and then you can safely proceed with the vaginal delivery. If the patient is coming with a third trimester, you better first deliver the baby by planned cesarean section, better under general anesthesia. In the same sitting, you go for the clipping of the aneurysm. So in the last trimester, it is always better to first go for a cesarean section, and mostly if it is not clipped, or if there is already a rupture has occurred, and if the patient's clinical and neurological status is not so good. So first we have to get the baby so that the baby is safe, and then you can go ahead with the clipping of the aneurysm.
Natasha,
So, yes, ma'am.
can you just sum up within 5 minutes?
Yeah. Okay, ma'am. So various strategies which can reduce the intraoperative ruptures should be always smooth induction. Like I already said, that you should excess hemodynamic responses to intubation and excess swings in the BP should be prevented. And the extubation also should be very smooth. And there is certain role of the pharmacological aneurysm stabilization also coming up with but this is only of study. Neuromuscular diseases, I'll be just quickly covering it. You all know what are the various parts: the muscle paralysis, pain, autonomic neuropathy, which may have intraoperative concerns like risk of aspiration, because these patients have bulbar palsy. These patients also have extreme sensitivity to your neuromuscular blockade. So there will be a prolonged neuromuscular blockade, plus there will be hyperkalemia to succinylcholine. So you should be careful. Post-operative respiratory failure may also occur here. And like I said, hemodynamic instability may occur because of the autonomic dysfunction associated in patients of GBS. And since there is a neuropathy involved, so there is axonal degeneration is there. So the sensitivity to local anesthetics is also very high. And so you have to give a lower dose of local anesthetic when you're giving a spinal. Coming to the myasthenia gravis, this is also an autoimmune condition which is having antibodies to acetylcholine receptors. But here, the one advantage as compared to GBS is there, because here the nerve is not involved, only the neuromuscular junction is involved. So here the regional anesthesia is very much safe, and you can very well give a regional anesthesia drug. And only you have to predict in the pre-operative period, apart from the history taking in the disease and medications, you have to predict whether the patient will end up in a myasthenic crisis or not. You can very well do a pulmonary function test, and if the patient is having a vital capacity of less than 2 liters, or if the duration of disease is more than 6 years, pyridostigmine requirement is extremely high, like more than 750 mg per day, or the risk of intraoperative blood loss is more than 1 liter, then all these conditions are usually associated with the risk of myasthenic crisis. So in these cases, you should always counsel for the risk of respiratory failure and ventilatory requirement. So anesthesia management, always give lower doses of all drugs, all GA drugs, which is possible. Always use shorter acting opioids. Like I said, regional anesthesia is safer in myasthenia gravis. Avoid the use of the non-depolarizing muscle relaxants. They are usually resistant to succinylcholine. So succinylcholine can be given, but repeated doses you have to avoid. They may cause phase 2 blockade in this group. A reversal agent, Sugamadex, although not available with us, but theoretically you should know that it is safer as compared to the neostigmine, because the patient is already on pyridostigmine. You will be giving neostigmine, they may land up in cholinergic crisis. And the stress dose of glucocorticoids may be given at induction. If the patient is already on steroids, yes, you may give. Other drugs which may put the patient at risk of crisis, you should always see antibiotics, beta blockers, and CCB, which you should always take history. Parkinsonism, this is a disease, neurodegenerative disease. Patient will be having some kind of tremors and stiffness in the body. They may pose with upper laryngeal muscle weakness also. So there are certain, almost all systems are involved, cardiovascular, respiratory. There may be lot of drug interactions, which because of the use of the dopamine inhibitors, the MAO inhibitors, sorry, dopamine agonist, which the patient will be taking. So you have to give your perioperative anesthetic agents also do interact, and there is increased chances of airway refluxes because of the sialuria. So here anticholinergics are best avoided. Please avoid atropine if you can, because that may also precipitate glycopyrrolate is safe, although because it doesn't cross the blood-brain barrier. Levodopa is to be continued on the morning of surgery. Regional is always safer. However, there are problems with monitoring. And inhalational agents, if you compare inhalational versus TIVA in this group, the TIVA is always safer because inhalational agents have certain actions of the dopamine and the glutamate level, so they may exacerbate Parkinson disease. And epileptic disorders, not much. You have to continue with the anti-epileptic drugs. So one important questions which always remain in mind when dealing with such patients, which is better, inhalational anesthesia versus the TIVA? There is a recent Cochrane meta-analysis by Miller et al. In 2018, and they have seen that there is not much difference between, and TIVA is not giving an additional, although the evidence is not so great. So absence of evidence does not mean that there is no evidence that it's, so still researches are going on whether which one is better, but then you have to judge as per the case, and you have to customize your plan. Like I said, balanced anesthesia regimen is always the safer approach. To summarize, always use a multidisciplinary approach, involve the neurologist, your neurointensivist, and preoperative optimization of the diseases have to be done. Balanced anesthetic approach, and also identify the high risk individuals so as to avoid post-operative problems and also your legal issues. So thank you. And if any questions are there, I would like to take it.
Thank you, Natasha. It's a wonderful presentation. There is no question in the chat box. I'll just ask you one question. Suppose a patient is in non-vitamin K oral anticoagulants. Okay, that patient having stroke and he has to undergo a elective surgery. So when should we stop? Is there any renal clearance we have to see for this patient or not?
Yes, ma'am. Usually, like you're saying about this newer orally acting,
dabigatran, rivaroxaban. Okay.
Yeah. So usually we have to wait for, madam, depending upon the creatinine clearance also, that is also important. So if the patient is having a good amount of creatinine clearance, 1 to 2 days is good enough. For patient is having renal creatinine clearance is not so good, less than 50 ml per minute. So 3 to 5 days are good.
Okay. Thank you, Natasha. There are a lot of questions, but because of the paucity of the time, I'm not able to ask. Anyway, it's a wonderful presentation and wonderful slide. Thanks a lot. On behalf of our ISABC, I must congratulate all the speakers. Now we'll move on to the last speaker, Dr. Vivekanand Sahu. He is a MBBS and MD and PDCC. He is a consultant in the neuroanesthesia and neurocritical care in Care Hospital, Bhubaneswar. And he's going to tell us about the venous air embolism, POVL, point of care ultrasound in neurocritical care. At present, as you know, as there is increasing number of the neurointensivists, they have gained a lot of experience in the skills in the use of ultrasound, and it will surely become an indispensable diagnostic and therapeutic tool. And I hope Dr. Vivek has come straight from the ICU or straight from the OT. Anyway, I welcome you to say such a beautiful topic, because we always come across with the problem of venous air embolism and post-operative visual loss and point of care ultrasound. Really, this point of care ultrasound is in the bedside, really it is very much helpful when the patient are in the ICU of the neurosurgery. Thank you. Or any neurocritical.
So,
Okay.
thank you, ma'am, for this beautiful introduction. Good evening to all my colleagues and juniors. As we are learning rate, I've chosen this topic because these are the most frequently asked questions in PG anesthesia theory papers, like venous air embolism and post-operative visual loss and ultrasound guided the measurement of optic nerve sheath. So starting from venous air embolism, we'll deal with definition, pathophysiology, clinical features, grading, diagnosis, and prevention and treatment. Venous air embolisms are embolic structures composed primarily of entered air that enters into the venous system of a patient. Air entertainment occurs when there is a pressure gradient between the venous opening at the level of the heart. It usually get a gradient more than 5 centimeters of water encourages air to enter the venous system. The other surgeries and risk factors for venous air embolism are elevated position surgeries, non-compressed venous channels in laparoscopic surgeries in cesarean sections, and in kyphoplasty or vertebroplasty, or in during pressurized fluid delivery systems. Even a central line insertion and removal can also cause venous air embolism. Neurosurgical procedures related to venous air embolisms are craniotomies in sitting position, posterior fossa surgeries, stereotactic surgeries, deep brain stimulation, craniosynostosis repair, torticollis corrective surgery, cervical laminectomy, and spinal fusion procedures. Air emboli often originates in non-collapsible cerebral venous. The venous sinuses in the brain are not collapsible like in liver. Mostly the air enters to the transverse sigmoid and the posterior of the sagittal sinus via venous channels in the diploic space within the cancellous bone of the skull. Other sites being the scalp veins, emissary veins, and intradural venous channels and tumor vessels. The sitting position is the classic procedure associated with venous air embolism. The overall incidence of venous air embolism is unclear as a result of variety of detection techniques. This is a common sitting position procedure. The incidence in posterior fossa surgery is reported to be 30 to 75% in the sitting position and 10 to 15% in the prone position or park-bench position. However, the incidence of hemodynamically significant venous air embolism is only 8 to 15% and 3 to 5% respectively. Overall, the consensus is the adult lethal dose is approximately 200 to 300 ml or 3 to 5 milliliter per kg. Coming to the paradoxical, what is paradoxical air embolism? Paradoxical air embolism occurs when venous air passes into the systemic arterial circulation through a patent foramen ovale or a ASD. The blockage of coronary arteries after paradoxical air embolism can cause myocardial infarction, and in the cerebral system it can cause cerebral infection. This is a post-op CT scan after a paradoxical air embolism causing MCI infarct. The incidence of patent foramen ovale in the general population seems to be relatively high, about 10 to 30%. Echocardiography also sometimes fails to detect a patent foramen ovale. Paradoxical air embolism can even occur in absence of patent foramen ovale, commonly via intrapulmonary transmission of air. To pathophysiology, elevation in pulmonary vascular pressure leads to impaired gas exchange, hypoxemia, and CO2 retention. Mechanical obstruction of pulmonary capillaries and increased intrapulmonary shunting results in decreased end-tidal carbon dioxide. Bronchoconstrictions may occur, and further air entertainment will lead to progressive decrease in cardiac output, hypertension, arrhythmia, and myocardial ischemia failure. Sudden entry of large air boluses can cause air lock, leading to sudden cardiac arrest. When there is fast entertainment of air, it causes a vortex of air in the right atrium and right ventricle, leads to immediate impediment of flow through heart, leading to sudden cardiac arrest. Slow entertainment leads to lead to air lodging in the pulmonary capillary, leading to functional decrease in capillary bed, increased pulmonary arterial pressure, decreased CVP, and right ventricular failure. It also leads to increased dead space. The same flow chart for paradoxical venous air embolism. Air enters the venous system, it goes into pulmonary circulation, there is right ventricular strain, increased pulmonary artery pressure, decreased venous return, decreased cardiac return, and cardiovascular collapse. When through the PA4 ASD, the air enters the systemic circulation, it leads to cardiac arrest or increased intracranial pressure or infarcts. Other symptomatology and signs of embolism are it can lead to arrhythmias, hypotension, change in heart sound, murmurs, electrocardiography, right ventricular failure or cardiac arrest. In pulmonary system, there is hypercarbia, hypoxemia, and pulmonary hypertension. In central nervous system, there is hyperemia and brain swelling. Post-operatively, we can observe myocardial ischemia, right ventricular failure symptoms, or in pulmonary system, we can see the perfusion defects through ventilator perfusion scans. In central nervous system, present as stroke or coma. Thrombocytopenia can also occur in venous air embolism. Intravascular air also induces direct binding of platelets to air bubbles, forming air platelet conglomerates. Platelet air clots affect air reabsorption, which might aggravate cardiopulmonary complications of venous air embolism. The microbubbles formed during the turbulent flow in circulation precipitate platelet aggregation, and the release of platelet activator inhibitors lead to platelet dysfunction and bleeding diathesis. It leads to use of there has to be presence of platelet function monitors like ROTEM or TEG to after if you suspecting thrombocytopenia. At a molecular level, venous embolism can lead to serious inflammatory changes in the pulmonary vessels. These include direct endothelial damage and accumulation of platelets, fibrin, neutrophils, and lipid droplets. Secondary injuries as a result of activation of complement and the release of mediators and free radicals lead to capillary leakage and eventual non-cardiogenic pulmonary edema. In awake patients, in DBS surgeries, a slow entertainment of air leads to characteristic gas or cough when 10% of the pulmonary circulation is obstructed. Accompanied breathlessness, chest pain, and sense of impending death can also occur. A rapid entertainment of air during awake surgeries in spontaneous respiration causes rapid shallow breathing at first, then shallow breathing followed by period of apnea next. There are different grading scales of VAE important in context of MCQs. The Girard scale and Tubingen scale and the Jadik scale. The Girard scale takes into consideration of precordial Doppler, the pulmonary artery pressure, and the end-tidal carbon dioxide and non-invasive blood pressure, invasive blood pressure. The Tubingen scale takes into consideration the transesophageal echocardiography and the blood pressure and heart rate. The Jadik scale classifies VA into minor, moderate, and severe. Minor clinical criteria for according to Jadik is positive transesophageal esophageal echocardiography with decrease in end-tidal carbon dioxide of greater than 3 mmHg. Moderate clinical venous air embolism according to Jadik is positive trans echocardial echocardiography with ABP decrease or heart rate increase, and severe venous embolism according to Jadik scale is positive TE with arterial blood pressure decrease of 40% or heart rate increase of 40%, including situations of cardiac respiratory arrest. Monitoring for venous air embolism include main monitor which is usually available in present OTs, precordial Doppler. It has a characteristic sound. It presents with a characteristic sound of Melville murmur. It is very sensitive for air. It is positioned over the right heart in the fourth intercostal space beside the sternum. May be difficult to place in some positions. That cautery, it may give false positive results in due to cautery, electrocautery, and IV mannitol after crystallizing may also give false positive signs in precordial Doppler. This is precordial Doppler present the right sternal border at 4 ICS. This is the from where we can hear the sound. This is the probe 2 to 2.5 megahertz probe. After application of the precordial Doppler, a 3 to 5 ml of agitated saline is pushed through the central line to check if the position of the Doppler is correct or not and it is working or not. Monitoring through TE, it is very sensitive, can also detect air in the left heart and aorta. It is qualitative, not specific for air, also detects fat emboli and blood microemboli. The disadvantages are it is large and difficult to insert in in awake patients and in in surgeries where the head is flexed. Monitoring end tidal carbon dioxide. End tidal carbon dioxide decreases after venous air embolism. It is only valid only if cardiac output and blood pressure are stable. It is affected by ventilation, awake patients, COPD, and decrease in cardiac output also causes decrease in EtCO2. So we have to first eliminate hypotension due to other causes before diagnosing as labeling it as venous air embolism. Monitoring end tidal nitrogen, it is specific for air. The end tidal nitrogen may occur 30 to 90 seconds earlier than those decrease in end tidal carbon dioxide. May not be sensitive enough, but it is very specific for air. End tidal nitrogen decrease may reflect decrease in BP rather than elimination of nitrogen. The presence of the monitor are not usually readily available worldwide, so this has become obsolete. Monitoring through a pulmonary artery catheter, there is increasing pulmonary artery pressure after embolism. Difficult to aspirate air through the small lumen of a pulmonary artery catheter. It requires expertise and it's invasive. The transcranial Doppler is helpful in paradoxical air embolism, where the air enters the systemic circulation. This is a summary of all the intraoperative monitoring we can use for air embolism. The TE has high sensitivity of 0.02 ml per kg. The precordial Doppler has 0.5 sensitivity of 0.05 ml per kg of air. The end tidal carbon dioxide and end tidal nitrogen has 0.5 ml per kg of detection rate. This is the we can see after a systemic air embolism through patent pharyngoemboly, you can see air bubbles in left atrium, left ventricle in a trans-echocardiographic view, trans-esophageal echocardiographic view. Different diagnosis of venous air embolism. There can be a tube disconnection which can in sitting position. So there can be hypotension, pulmonary thrombolism, myocardial infarction, all can mimic venous air embolism. Prevention in awake patients, which we should start positive pressure ventilation to prevent further air entertainment into systemic circulation, ensure adequate hydration, minimize head elevation. That surgical techniques should be adequate to cauterize all the veins, bleeding veins. We should avoid nitrous oxide and avoid drugs that increase the venous capacitance. Military anti-shock trousers are available to increase the pressure, venous pressure, so that the veins are not the air is not entered into the open veins. Acute management of a venous air embolism event. The surgeon should pack the surgical feed with salines of gauze, apply wax to the bone edges, cauterize the possible source of bleeding, discontinue nitrous oxide, apply 100% oxygen, manually compress the internal jugular veins. If change the patient to Duran's position, which is head down and left lateral, to prevent the airlock and to prevent air entering the right ventricular outflow tract. We should also attempt aspiration of air from the right atrium. And in case of cardiac arrest, we should start immediate vasopressors and volume infusion. Bilateral compression of the internal jugular veins can also dislodge carotid plaques and cause bradycardia if carotid sinus is manipulated. To allow aspiration of air from the right atrium, the multiluminal catheter should be positioned 2 cm below the junction of the superior vena cava of the atrium, or if you are using a single lumen catheter, it should be positioned 3 cm below the junction. Placement of a central line should be usually done through intravascular electrocardiography through a and it is confirmed by a biphasic P wave, which allows us to place it in the junction bit of the superior vena cava of the atrium. As we progress toward the sinoatrial node, the move away from the sinoatrial node, the P wave becomes negative. As we move towards the sinoatrial node, the P wave becomes positive. So at a point where the P wave is biphasic, which confirms the junction between the sinoatrial node, junction between the superior vena cava and the right atrium. The addition of PEEP is controversial. Addition of PEEP to ventricular settings should be avoided because it can increase right atrial pressure and potentiate the risk for paradoxical air embolism. To conclude, preoperative checkup and risk evaluation planning should be done. Intraoperative real-time monitoring and eternal vigilance should be done. Adequate hemostasis should be maintained, and strict adherence to established protocol should be done. And it should be collaborative approach for the neurosurgeon and neuroanesthetist. Starting for post-operative visual loss following surgeries. Post-operative visual loss is a rare but devastating complication with incidence ranging from 0.02% to 0.2%. It is defined as a partial or complete vision loss after non-ophthalmic surgeries. POVL is known to occur after various surgeries such as cardiac, spine, orthopedic, endonasal, and urological procedures. The incidence of perioperative vision loss following procedures of spine is 0.05% to 1%. These are the optic pathway, and the causes of injury according to the in different parts of the pathway causing post-operative vision loss. In the cornea, post-operative vision loss can be caused by direct injuries or exposure keratitis. In the retina, it can be caused by external compression, emboli, or hypotension or vasospasm. In the optic nerve, it is caused by ischemic optic neuropathy or direct damage. And in the cortical areas, it can be caused by emboli, systemic hypotension, or direct damage. Causes of POVL: external ocular injury, retinal ischemia, ischemic optic neuropathy, cortical blindness, and acute congestive glaucoma are mostly cause POVL in post-operative patients. Coming to external injury, directed trauma to the globe or prolonged exposure to the cornea can lead to exposure keratitis, corneal abrasions or lacerations, or globe perforations. These injuries vary in severity from self-limiting injuries to severe trauma necessitating surgical intervention. Coming to retinal ischemia, the common cause of retinal ischemia is central retinal artery occlusion. CRO occurs due to direct compression of the globe after spinal surgeries in prone position. External injuries are usually associated with CRO. Certain facial anomalies such as altered facial anatomy, osteogenesis imperfecta, exophthalmos, lower nasal bridges in the patient moving to Asian descent increase the vulnerability to external compression. At the cellular level, retinal ischemia incites excitotoxicity, hyperemia, and hypoperfusion, which aggravate blindness. Complete occlusion of the central retinal artery gives pale appearance to the retina on fundoscopy, while the macula receives blood through the choroidal arteries appears red, due to cherry red spot. Patients present with painless vision loss and abnormal pupil reactivity. There is no beneficial treatment of CRO. Recovery of vision is typically poor. These are the most common causes. Actually, the CRO is also known as the headrest syndrome, caused by the inappropriate placement of headrest in prone position surgeries. To prevent CRO, we can use a mirror after positioning the patient, or take a selfie with a mobile phone to check the position of the eyes, they are free or not. If at all, we can use pin type holders instead of a horseshoe headrest to prevent POVL.
Can we just find up 5 minutes more?
Yes, ma'am, of course. Coming to ischemic optic neuropathy, ION is the most common cause of sudden visual loss in patients undergoing posterior final fusion. Two types of ION, anterior and posterior. Injury to the optic nerve anterior to the lamina cravosa is classified as ION, and injury posterior to the lamina is called PION. PION is more common in spinal surgeries. ION is atretic and non-atretic. The fundoscopy exam in early PION is completely normal, whereas in AION will demonstrate optic disc edema with or without peripapillary flame-shaped hemorrhages. PION presents with more severe impairment than AION, as the posterior portion of the optic nerve travels through rigid, fixed, inflexible structures, and optic nerve swelling leads to more intense axonal compression. This is the optic nerve, and we can see the anterior part is having much more collateral circulation rather than the posterior part. The region of ION, this is the region of the ION, and this is the region of PION. So PION is more common. AION is more common in cardiac surgeries, and PION is more common in posterior spinal surgery prone position. Risk factor for PION are hypertension, coronary artery disease, diabetes, obesity, vascular disease, and tobacco use. Perioperative factors include prolonged duration, anemia, excessive crystalloid use, and present use of Wilson frame. This is a flow chart for the pathophysiology. Substantial blood loss causes inflammation, capillary lower oncotic pressure, interstitial edema, increased IOP, accumulation of fluid in optic nerve sheath, and which causes a direct mechanical compression and venous infraction leading to ION. Obesity causes increased abdominal girth, which causing venous compression, which causes decreased cardiac output leading to ION. The Wilson frame doing spinal surgeries, the head remains below the level of heart, which causes venous outflow obstruction and leading to ischemic optic neuropathy. This is the cherry red spot in CAO because of the as the macula is supplied by choroidal arteries, it is spared. The rest all retina becomes pale. Cortical blindness, another cause of POVL. The cause of cortical blindness include focal ischemia, cardiac arrest, hypoxemia, and vascular occlusion or emboli. Patient presents with sign of stroke in the parieto-occipital region. Patient will typically have bilateral involvement. They may recover spontaneously. The prognosis is better than ION, PON, and CRAO. This is a summary of all the causes. The CRO is immediate and unilateral. The cortical blindness is immediate and bilateral. The POVL is bilateral. The prognosis of cortical blindness is better. The prognosis of ION and PON is poor. There is no established treatment also available. Acute angular closure glaucoma can also precipitate causing post-operative vision loss in prone position surgeries. Posterior reversible encephalopathy syndrome. The symptoms include headache and post vision loss. There is symmetric edema in the subcortical white matter. They are precipitated by hypertensive episodes exiting the autoregulatory capacity of the cerebral vasculature. It can be confirmed after MRI. The American Society of Anesthesiologists has promulgated an advisory in 2019 regarding to prevent POVL. Just to summarize, considering the first point is considered consenting patients undergoing major spine surgery for risk of POVL. Continuing monitor blood pressure, minimize use of deliberate hypotension when possible, keep head at level at heart level. Periodically monitor hemoglobin and hematocrit, avoid direct compression of the globe, and consider staging procedure. In setting of POVL, immediate management is directed toward optimizing hematocrit, hemoglobin, hemodynamic status, and urgent ophthalmic consultation should be done. If an injury to the eye or central retinal occlusion is excluded, neuroimaging with MRI has to be done. There is no proven effective treatment for the spontaneously occurring CRO or ION. Experimental selective thrombolysis for spontaneous CRO has mixed results. Case reports for hyperbaric oxygen therapy, mannitol and steroids also have inconsistent results. Thank you. Just a few slides about optic nerve sheath diameter in neurocritical care. The optic nerve as a part of the central nervous system is surrounded by subarachnoid space and experiences the same pressure changes as intracranial compartment. The intraorbital part of the sheath and particularly its retrovolar segment can distend when the ICP is elevated. The use of bedside ultrasonography is in measuring optic nerve sheath diameter can be a useful method for detecting raised ICP. Patients are examining the supine position using a high frequency linear probe. A thick layer of ultrasound gel is placed on the eyelids after tegaderm application. The structure of the eye were visualized on the ultrasound to align the optic nerve directly opposite the probe. This is the 5 MHz probe. The tegaderm is applied above the orbit. The probe should be gently placed over the eyelid, paying careful attention not to exert too much pressure. In each plane, the probe is adjusted from the temporal to the nasal end to find a suitable angle for displaying the entry of the optic nerve into the globe. This is the optic nerve. The optic nerve will be placed in the center of the image before making the measurements. The optic nerve sheath diameter is measured 3 mm behind the globe by convention. It is due to the ultrasound contrast is greatest after 3 mm. It is according to consensus. The two measurements in two planes, axial and visual, are taken, and average is recorded as final measurement. The cutoff value is is taken as 5 mm. It is sensitivity. The sensitivity of this USG guided nerve sheath diameter is 93%, and specificity is 96%. This is 3 mm. Yeah, okay. Advantages of This method is reproducible, non-invasive, rapid, low cost, non-icing, and it can be done bedside. Disadvantages are lack of uniform cutoff, operator dependent, and potential risk of pressure to the globe. False positive can occur in optic neuritis, arachnoid cyst of the optic nerve trauma, or in cavernous sinus masses. To conclude, can be used as screening tool ED as a surrogate market for raised ICP. ICP monitoring through ventricular drain remains the gold standard. This method being non-invasive can be repeated multiple times. Further studies are required to validate its usefulness in raised ICP patients. Thank you.
Thank you, Dr. Vivek. It's a wonderful talk. There is no question for you in the chat box. One last question and we'll wind up. Is there any prognostic value of the optic nerve sheath diameter in patient with subarachnoid hemorrhage?
Yes, ma'am, of course. Sometimes when the CT scan is full or something, patient is CT scan is not available somewhere in some peripheral centers. If you have an ultrasound, we can gauge the raised ICP after doing an optic nerve sheath diameter measurement, and we can sense the urgency after seeing if the ICP is raised or not.
Thank you. It's a wonderful session. I think, Gauram, I am handing over to you. It's a really it's a very good. All the speakers are excellent speakers, and they have enlightened us with excellent knowledge. And I am sure it will be definitely helpful for all the postgraduates.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you to all the speakers, all the participants for this session, and I hope we will get more attendance and more participation in the future upcoming events, and probably one or two more webinars we will do, and then we'll start our in physical CME as before. So thank you, and thank you one and all. Thank you so much.
Thanks a lot, Gaurav and ACDC.
This will be recorded and put on our ISA YouTube page. Thank you.
Thank you, Dr. Gaurav. Thank you, madam.